and prior to that, I was a registered general nurse. So I did my doctoral research around pregnancy after stillbirth and exploring the experiences of couples in pregnancy after stillbirth, and that really came from my clinical practice, because at the time we were amalgamating 3 maternity hospitals into one large maternity unit, and I was wondering what that was going to be like for the couples having to return to the same maternity services, whereas previously they would have had a choice. Now they weren't going to have any choice, and I wondered what that was going to be like for them, and that's really where my research question came from. And I suppose I ended up going down into the depths and the down into the literature on pregnancy after stillbirth, and I met some amazing people, including Dr. Joanne O'Leary, who's been working in this area for many years, and I just want to acknowledge her work, because her work really has influenced my work, and just to say that at the outset. And that really was where I was coming from, and I was really interested in couples, because the majority of pregnancies occur within a couple. Not all, but the majority do. And I was very conscious that men, fathers and men, their experiences were really not explored very much. So that's where my research background came from. So just to say at the outset, I don't have any interest to declare. My research wasn't funded by anybody. It was my own funding, and just to say that at the outset. So I'm going to try and share my screen with you there, Paula, and see how that goes.
Yeah. Do you see the share button up at the top right?
I do.
Yeah. And then just click on your presentation.
Go there.
Should work. Perfect. Perfect. And if you want to put it onto presentation mode, if you go down to the...
Do you have the full... Do you have the full screen there?
It's not on the presentation mode. So if you want to go down to the presentation mode down in the bottom there, next to the sliding button for the zoom. Yeah, exactly. Yeah.
Okay.
Let's see if that works. Just try it again. It's still in the normal mode.
Normal mode.
Sometimes it doesn't. Sometimes it doesn't work actually to do that. There's another way to do it on. Yeah, exactly on the top. To.
Let me just see here now.
See, it's looking as well.
How's that there now?
I mean, we can see it fine. The slides are up, but just we see the whole thing. You know, it's not in presentation mode.
Okay, I don't know.
Try
I don't know why
present in team. No, that's done. Okay, don't worry, don't worry. Just it's fine. We can see absolutely fine. Oh, Barbara, if you got a suggestion, you're Teams expert. I'm so useless.
I'm just wondering, Margaret, if you know when you were going to share it, if you had it open on full presentation, I wonder can you share it that way, like it's opened up, like on your.
If I open it first, Barbara, you mean?
Yeah, open it first and then share it. It might.
Okay.
I find that might work, Margaret.
Okay, let me do that.
Perfect. Well done.
Thanks, Barbara.
Yeah, well done, Barbara.
Oh.
Okay. So is that okay?
Yeah, it's perfect. I'm just gonna mute everyone. Off you go,
Okay.
Margaret. Thank you. Yeah.
And now my slideshow won't move on. Apologies, now my slides won't move on.
Don't worry. And if you just press enter, does that work? That sometimes will work. Or the button down.
No, the arrows.
The arrows are not working.
Any ideas, Barbara?
Our Teams expert.
Yeah, I am. It's
The
a funny.
the team's gremlins are out today.
Yeah,
Oh,
you
yeah.
see, I'm going to put my hand up and say that I'm a Zoom person. We're only moving to Teams where I work, so I'm not as familiar with it. But I'm just wondering, yeah.
Margaret, why don't you email me the presentation and I'll try to share it, and you can just talk in the meantime while we're doing that.
Okay. Let me just email that to you.
Apologies, everyone, but sure. Life wouldn't be any fun without a technical glitch, eh?
Now I've just sent that to you there.
Brilliant. I shall. To my DAI email?
Yeah.
Yeah. Okay. Good. Sure, it'll come in a sec. If it's quite large, it might take a while to come to me. You can just maybe start, Margaret, and I'll put it up as soon as it comes in.
Okay, just to I suppose just to give an introduction and just say that the presentation refers to pregnancy after stillbirth and also pregnancy after loss, or PAL, as that's what's discussed in the literature. The presentation also refers to women or mothers and men or fathers when discussing the pregnant or non-pregnant partners. And this is because the current data that we have reports on studies with predominantly white heterosexual couples in high income countries. So further research is required with non-white couples, with individuals, with pregnant people who do not identify as women, with non-pregnant partners, same-sex couples, and people in low and middle-income countries to gain their insights, because the current research we have is quite homogenous. So we know that perinatal loss is the most common complication of pregnancy, and that an estimated 1 in 4 pregnancies will end in miscarriage, defined as pregnancy loss less than 28 weeks. Stillbirth, thankfully, is less common. In Western Europe, the rates are 3 in 1,000 births, in the global south, we know that stillbirth rates are much higher. In India, for instance, it's 14 in 1,000. In areas like sub-Saharan Africa and Sudan, for instance, 22 in 1,000. And that the responsibility is on all of us. The WHO talks about ending preventable newborn deaths and stillbirths, and the need for better health care, particularly around the time of birth, and the benefits that would have on outcomes, both in terms of reducing stillbirths, but also in reducing neonatal deaths. Many studies have looked at the effects of stillbirths, and Heasel et al. Have looked at the economic and psychosocial consequences of stillbirths in terms of not just health service utilization, but also the psychosocial consequences on women. And therefore, health services and researchers have worked towards, looking at things like improving healthcare around the time of stillbirth. Looked at looking at stigma, and looked at reduced earnings, and looked at what governments, for instance, can do on supporting women in particular, but also men, on the effects of stillbirth.
Sorry, Margaret, I'm just checking you have sent it because it hasn't come through yet. It doesn't usually take that long. Just check that it went from your outbox.
Okay, it's just saying it couldn't be delivered.
Ah.
Okay.
Right. Would you want to try again then? Just leave it. Again. Don't worry about the presentation mode. If it moves down, we can see it very well. So
I've increased the size of the let's see there now. I've increased the
arrow. You see, and you are here giving me money.
How does this look?
Yep, that's fine.
I know you're seeing.
Yeah, no, we can, but it's fine. We can read it. It's fine, Margaret.
So studies have also looked at couples' experiences in care following stillbirth. So in 2018, Wojciech et al. Published an online survey of 2,716 parents from 40 high and middle income countries, and looked at their experiences of care in pregnancies following stillbirth. And what they found was that most parents, 2/3 of them, were pregnant again within a year of stillbirth, and that physical care was quite good for the majority of women, particularly around antenatal care and the provision of ultrasound scans, although there was a wide variation across geographic regions, with say, for instance, the Western European, Northwestern European, and the north of North America and Australia faring better in terms of care provision. The care addressing psychosocial needs, however, fared worse in terms of access to bereavement counsellors. That was quite poor. only 10% of women gained access to services such as a bereavement counsellor. So services tended to be good in terms of addressing physical care, not so good in terms of addressing psychosocial care. Likewise, if the loss tended to be less than 29 weeks, care was not as good, whereas if the loss was greater than 30 weeks, they were more likely to receive additional forms of care, including the option for early delivery. Around half of parents felt that enough elements of quality, respectful care were consistently applied, such as spending enough time with parents and involving parents in decision making. And that varied as well from 47 to 63%. So it was seen that there was a lot of work to be done in terms of addressing care in subsequent pregnancies following stillbirth. So in my study, it was a small qualitative study. I looked at, couples' experiences of pregnancy after loss. And one aspect I looked at was how couples decided to get pregnant again after their experiences of loss. And the couples talked about their decision being a joint one, that they negotiated as a couple. They also spoke about the fact that the women within the couple unit tended to be readier to become pregnant again earlier than the men in subsequent pregnancies. And the men in the couple units tended to require more time to attach and parent to their deceased baby before considering a subsequent pregnancy. And that was very important, particularly for fathers, around anniversaries, around times when babies should be due, so babies' due dates. Fathers were very insistent that around protecting each individual baby's, one father called it, I want to protect that baby's time because that's her time. So it was almost as if the fathers were separating out each child, one from the other. The mothers were very well able to differentiate between their babies, and they were able to attach fetal personhood to each separate child, whereas the fathers tended to want to make more time between each baby once the babies had been born. Their decisions tended to be context dependent. By that I mean the decisions tended to be based on the type of loss that they had experienced, whether their babies had died suddenly or whether their baby's loss was anticipated. So whether their babies presented, for instance, with decreased fetal movements and they had been told that their baby had died, or whether they had presented at 20 weeks and had been told that their baby had a fatal fetal anomaly and they had time to process the fact that their baby was not going to survive outside the womb. The cause of their baby's death was also tended to be a context that influenced their decision. So whether their baby died as a result of a life-limiting condition, So whether their baby had a fetal anomaly that, say, required a genetic investigation, or whether their baby had some type of placental condition, whether their baby had died from infection, whether their baby's death was unexplained. Those types of context seem to influence their decision to get pregnant again. Also, their relationship issues, so their grieving styles. So whether their grieving styles were feminine or whether their grieving styles were masculine. And it didn't necessarily follow that all women had a feminine grieving style and all men had a masculine grieving style. Sometimes there were men who had feminine grieving styles and women who had masculine grieving styles, but it depended on what type of grieving styles the couples had and whether there was conflict between those grieving styles, and that seemed to influence whether they were in a position to decide on to get married or to get decide on their pregnancy again. So many services are now developing clinical guidelines on caring for couples again in pregnancy after loss, including our own services. And in 2023, Professor O'Donoghue led out on the National Women and Infants Health Programme guidelines on stillbirth prevention and investigation, management and care. And as part of that guideline for the health service, there is a section on pregnancy after loss. And in those guidelines, it talks about the fact that pregnancy after loss is a high risk pregnancy, and the fact that the greatest risk of stillbirth is a history of stillbirth. So therefore, women in pregnancy after loss are at increased risk of pregnancy loss, and also at increased risk of pregnancy complications. So the aim of care, therefore, is to identify risk factors, to reduce recurrence rates and aim to improve psychosocial care. So it's important to identify and treat the cause of the index loss. So looking after women who've had a stillbirth and providing good care in the first instance, and then initiating quickly investigation. So that might be things like serial ultrasounds to detect growth restriction. It might be to start treatments early, and that might be something like aspirin or low molecular weight heparin if it's required. It might be to identify and treat modifiable risk factors. So issues like raised BMI, increased blood pressure, smoking, so implementing smoking cessation, encouraging women when they are pregnant to settle to sleep on their left side, encouraging fetal movement awareness. Again, increasing surveillance from an earlier time point. Although these lead to greater health service utilisation, the benefits are great in terms of reduction in stillbirth recurrence. There may also be an increase in rates of early birth, and that may be due to existing comorbidities, or it might be due to planned induction of labour or elective caesarean section, and that might be due to anxiety or discussion and plan of birth on the the woman's part in consultation with her obstetrician. And we know that specialised pregnancy after loss multidisciplinary clinics improve or have been demonstrated to improve couples' experiences. But more research is needed to demonstrate improvement in other outcomes. The Centre of Research Excellence in Stillbirth in Australia have also recently published their clinical practice guidelines in care around stillbirth and neonatal death. And within those guidelines, they have a section on care in subsequent pregnancies. And their objectives are in providing best practice care for parents and families in pregnancies following stillbirth or neonatal death. And that includes meeting parents' medical, social, and emotional needs and providing pathways to specialised care, in providing parent-centred decision-making and care planning, including preconception counselling, pregnancy management and consideration of timing of birth, and coordinated care across health and community services, the provision of culturally safe and responsive care, and supporting well-being of parents, including referral to support. So there's a link there to that guideline as well, which is only recently published. So physical care is very, very important for women pregnant after loss. But the psychosocial needs of couples is also tremendously important. This is a very famous photograph taken of a high wire act, and he's walking between the now demolished Twin Towers in New York City, and many parents would describe pregnancy after loss in a similar way, that it's a bit like a high wire act. You know, anxiety and fear really are key features of pregnancy after loss, and they coexist with restrained hope. So parents are really trying to put one foot in front of the other throughout their pregnancy after loss. But at the same time, they are trying to retain hope for one another. They need emotional, informational, and practical support. And continuity of carer has been demonstrated to be beneficial to them. Someone who knows them, someone who knows their history, and someone who knows their deceased baby has been demonstrated to be very important. They need increased access to healthcare staff and services because they need reassurance of fetal well-being. They need proof of life. And oftentimes they will need that because they will be unable to contain their anxiety and fear. And at that stage, they will reach out to health services to obtain that proof of life. And that may be a sonic aid, CTG, or ultrasonography. What I found in my study was that the women in the study were very, very happy with sonic aid or CTG, just to hear the baby's heartbeat. The fathers, the men were really needed to see the baby. They needed to see the baby and they needed to see the baby moving. They were far more reassured by ultrasonography than they were by CTG. So in terms of supporting and communicating with the couple in pregnancy after loss, their experience is completely different to the non-bereaved couple, and that's due to their loss of innocence. There's a heightened sense of fear and anxiety. The worst outcome has happened, leading to a lack of trust in a positive outcome. And for women, that lack of trust is in their own bodies, and that is very, very distressing and debilitating for themselves. So initially, couples will be searching for control and proof of life, internally first, and then externally. So they will, women will be reassured initially by fetal movements. The father will be reassured by the mother's fetal movements. But sometimes as pregnancy goes on, even fetal movements may not be enough to reassure them. There is an enduring bond and loyalty to the deceased baby that is very strong and needs to be acknowledged and recognized, because this enduring bond delays attachment to the baby that is here. And Dr. Joanne O'Leary, in her model of attaching to the newborn baby that's coming, talks a lot about this antenatal attachment process, because this is a protective mechanism, because the woman doesn't want to get hurt again. She doesn't want to love this new baby that's coming in case this new baby also dies. One of the women that I interviewed in my research talked about that. At 36 weeks, she was, when I was interviewing them, she was talking out loud and she was saying, but I don't want to love this baby, but of course I love this baby. Of course I do. But it's almost a protective mechanism that they don't want to believe in their heart. They know in their head this baby is coming, but they don't want to believe in their heart that this baby is coming in case this baby dies. And they also don't want to betray the baby that has gone before, because if they love this baby, then that may be seen as being disloyal to the baby that has died. And Dr. O'Leary talks a lot about that in her model of antenatal attachment, loving both babies. So there's a lot of psychosocial needs for couples in pregnancy after loss. And particularly if parental grief is not recognized, it can become disenfranchised. We know that for a long time. And of course, there's a risk of pathologizing grief. And that's very challenging too. And we need to support couples in parenting all of their children. The deceased baby, the expected baby, and any surviving siblings. So there needs to be continuing bonds to the baby that has died. Parents need to parent and try to attach to the baby that is coming, and couples need support to help parent the surviving children, because they too are grieving their brother or sister who has died, but they're also grieving the loss of the the parent that they knew. And this is very important, that the extended family and community are aware of this, but also that the extended family and community can help with supporting parents in this, in parenting all of their children. Of course, parents are going to have concern for the surviving siblings, but parents may be so overwhelmed by grief, they may be unavailable to their surviving children, particularly if children are young and their repetitive questions, as they try to comprehend, may be difficult for parents to cope with. Honesty, openness, and transparency are what are recommended, particularly at children's developmental stage and their developmental concept of death in terms of finality, universality, non-functionality, and causality. So depending on how they understand those concepts. And it's important to look at the child's behavior over their experience. Because some children will cope very, very well with their siblings' death, as long as it's being dealt in an honest, open, and transparent way. And as I mentioned, they're not only losing their sibling, but they're also losing their parents as they knew them. So what helps? So good physical care to reduce the risk of recurrence. So we mentioned the guidelines, but also things like the Safer Baby Bundle. There's a link there to the Stillbirth CRE in Australia. And they introduced the Safer Baby Bundle, and there's some nice infographics there around timing of birth, fetal movements, sleeping on your side, trying to identify women whose babies have fetal growth restriction, smoking cessation. Just being mindful that women and their partners share a common event, but they may have different experiences of that event, and they may make sense of the event differently, and therefore they may have different support needs in pregnancy after loss. And also that men's experiences and needs are often overlooked, not intentionally, but that may happen. And so therefore, care may need to be tailored to each individual couple. And this is just one example. This is just a book that we wrote for parents on pregnancy and parenting after loss. It's called Different Baby, Different Story. So good quality, respectful bereavement care at the time of loss is helpful. Acknowledgement of the baby who died and of the couple's parenthood of that baby. I mentioned continuity of carer, additional appointments and scans. Being mindful that they don't remove the anxiety, because there's no point at which stillbirth can be ruled out. And there's no point at which women and their partners will feel safe. Having care in a service dedicated to parents with a history of stillbirth certainly helps reduce feelings of isolation. And having dedicated antenatal education services, because oftentimes women may experience stillbirth even before they've had an opportunity to attend antenatal education or prenatal education services. And they may not want to attend antenatal education classes with women who've never experienced a loss. So what's next? Well, there is the development only recently of Rainbow Clinic Network set up by the University of Utah by our colleagues there, Dr. Bob Silver, Dr. Susanna Hopkins-Lisher, and also with our colleague over in Manchester, Professor Alex Heasel. And Alex has been running Rainbow Clinics in Manchester for many, many years now. And he's developed a model that has been rolled out in the UK of Rainbow Clinics, so specific pregnancy after loss clinics. And there are links there to those clinics for you to have a look at for further information. So learning from one another, coming together, learning from one another, providing dedicated clinics for women and couples, and doing further research really would be helpful. And just to say thank you to ISA for inviting me to present today, and just immense gratitude to the couples who shared their experiences and their family narratives with me when I was doing my own research. And sorry about the technology issues. Thank you very much. Thanks, Paula.
Thank you so much, Margaret. That was amazing. Fantastic research. So helpful for all of us who, anybody who works in this space. And I'm sure a lot of those messages will be incredibly familiar to many of you. So we invite you to turn on your cameras, and if you have any questions for Margaret or any comments, I've seen a few comments in the chat already. So yes, the name of the book, Margaret, maybe you can put that into the chat so that everybody can access that. And if anybody can't access the chat, let us know. But we can send it out afterwards as well. So, any questions for Margaret, or any comments? Anybody like to say anything? Please do. Just unmute yourself and go ahead. Kerry Jones, please, Kerry.
Hi, thank you. Thanks for a wonderful presentation. Absolutely brilliant, thank you. It echoed quite a bit of research I've undertaken with couples, and now my focus is more on men. One of the things that I've heard from couples over time is around the subsequent pregnancy and the antenatal care, which you've spoken about, and the kind of responsiveness from professionals to those couples, because obviously they're anxious, and you've talked about attachment, etc. What do you think could be done to kind of support professionals to kind of respond in a way that parents feel that they're maybe listened to, or their anxieties are quelled a bit? Because it's not always apparent that there's been a previous loss. Sometimes there's like a footprint sticker and that gets lost, So I wonder what your thoughts were about on that particular issue.
Thank you very much, Kerry, and it's great to hear that you're doing research, particularly on fathers. So so Barbara and myself, along with colleagues of ours in Ireland, we developed perinatal bereavement education standards, because we first of all, Professor Keelan O'Donoghue leads out on the bereavement standards, the national bereavement standards here in Ireland. So those were developed back in 2016, and as a result of those clinical standards, it was felt that we needed some type of education standards for the clinicians working with all bereaved families. So we took the perinatal palliative care model of all, some, few, and we developed a set of perinatal education bereavement standards based on that model that have been applied across the 19 maternity units here in Ireland. So all staff working in our services get, depending on their role within the services, will get some type of bereavement education. The second thing to say is within the services, then we have developed some type of alert system. So if couples have had a bereavement within our service, I'm not sure what the current situation is in Dublin, Barbara, but in our services in Cork, there is an alert system. We have a teardrop, and that alerts all staff to the fact that couples have had a bereavement, and so everybody is aware that this couple have had a bereavement, and so to care for them with additional empathy and care.
Thank you. Once again, thanks for the brilliant presentation.
Thank you very much.
Thanks, Kerry. And I'm just going to post also a link to the one of the toolkits that ISA developed, which is focused around advocacy with healthcare providers following stillbirth, Kerry. It's a generic, it was actually developed in India, so it's a little bit geared to that context, but there's a lot of stuff there that, we feel is very useful for other parts of the world as well, not just in India and in Asia. I'll also put a link to the other toolkit, well, both toolkits. So we have a toolkit that was focused around parents and them raising their own voices, and one for healthcare providers. So I'll put both. I'll put the general link into the chat as well. And please, people, do feel free to explore these and our other resources. And ISA, thank you. Any other questions? Any other hands up? Barbara, go for it.
Hi, Margaret. That is really great to hear about the work that you're doing and the work that you have done. And I suppose one of the questions, a long time ago, I did some work looking at the impact of sudden infant death on children and families. And what kind of strongly emerged from that was that both parents are, very important to the children, but it was the mother's well-being that really, in many ways, determined how well the children progressed. And that was not in any way unfair, the fathers weren't, but it just seemed to be that connection. And I just wonder, as you were meeting the parents, how did the mother describe that to you? Would you have seen something like that? Because obviously in this situation, the mother is also, as you've said, within a year, focusing maybe on becoming pregnant again. And it's interesting that you said that the fathers are a little bit, want to have another pregnancy but want to wait a little bit more time, and the mothers are so focused on that. So I just wonder, in that context, what was your sense of the mothers as you explore that with them in terms of their children? Obviously not every mother would have had younger children, but in those families that maybe did have younger children, or your experience when you were working clinically, how did you find them on, or that relationship? How do they manage that for themselves?
Thanks, Barbara. I think that the fathers, and Kerry's research, I'd be interested to hear Kerry's research. I think the fathers continually assume the role of, protector of the family. I think there's always a delay in grieving for the fathers within the couples. I certainly found that within the cohort that I looked at. The fathers were very concerned about the mother's physical well-being, the mother's mental well-being. Several fathers talked about giving women a baby. So, you know, if the woman wanted a baby, giving her a baby. So this idea of, you know, not necessarily, I won't say not wanting a baby, but, you know, if that was what, so she was so driven to have a baby in the in a subsequent pregnancy that I kind of gave in, and I gave her a baby, you know. But I certainly, in the cohort that I was involved with, it very much seemed like the men were the gatekeepers for the subsequent pregnancy. The women were really anxious to get pregnant again. Now, they were very, very adamant that it was not to replace their deceased child, because they were very definite about the personhood of the baby who had died. So they were very definite that this was not to replace their deceased baby, but they needed another baby. They needed to parent another baby, but it was not to replace their deceased baby. And that sometimes, I think, is where psychologists in the past have talked about a replacement child. These certainly in the cohort that I was researching, these women were very adamant these were not replacement babies. They said, I want this baby, i.e. the baby that died, but I also want this new baby. And I'm very definite that's that baby and this is this baby. The fathers found that much more challenging because of parental attachment, because fathers really are unable to attach until they have an outside baby. You know, their transition to fatherhood is much more challenging. It's not complete really until they have an outside baby. And several of the fathers talked about it wasn't until their deceased babies were born that they were able to parent that child. And they needed that time then, so to protect that baby. So I needed to be able to parent that child, and I didn't want to get pregnant again, because that, as one father said, that was her time. I wanted to protect her. That was her time. I didn't want to be pregnant again, when she was due. I didn't want to be pregnant again on her anniversary, the anniversary of her death. I didn't want to be pregnant again on the anniversary of her of when she was due. That was all her time. I wanted that for her. But their partners were much more anxious to get pregnant again. And so the the the, the fathers whose babies died as a result of congenital anomalies, they were able to kind of say, well, hang on a minute, we'll wait now until we have the post-mortem result. We'll wait now until we have the genetic counselling done. We'll wait until we have all the test results back. The fathers whose babies died very suddenly were in a much more challenging position, because there was that shock of the suddenness of their baby's death. They tended to get pregnant much quicker. Sorry, Barbara, the other issue,
No,
the other
sorry.
part of your question you asked.
No, it was really just to see in when you were talking to the mums and that in terms of the
About the other
relationship with, yeah, and how, because that's, as I say, very hard for them, that the children do need their mothers.
Yes.
In term, and obviously their fathers as well. But it just in previous research, I found that the mother was so important to that the child's grieving, adjusting to the loss.
I'll give you an I'll give you an example of one mother. And again, it really spoke to the idea of their parenting, their other children being completely different, you know, after their death. One mother talked about so her baby's death was as a result of a twin. So one of the twins died and the other twin survived. And she had a little boy who was 4 or 5, and she had told this little boy that there were going to be 2 babies coming home. 2 babies, 2 babies, 2 babies, 2 babies. And then when the twin died, she said when the baby came home, he was like, well, where you said there were 2. Where's the second baby? And she essentially gaslit the child. She said, "Oh no, there was always going to be one." And he was a very I met all of her children, and he was a very clever child. And he was like, "Hang on a second. You told me there was going to be 2." And she was like, "No, no, always ever going to be one." And he was going around the place like, this is weird, you know? And I think his trust in her was completely shattered because, you know, she really told him a big lie, you know? And her relationship with him really was fractured. But she wasn't in any position to, I think, do anything different.
Mm-hmm.
I felt very sad for her because she was coping the best way she could.
So it shows the importance of thinking about families that have siblings and how they're going to manage that grief and bring the family with them. So thank you, Margaret. Thank you very much.
And support, Barbara. And that, just to say that girl had no support from her family. And the importance of family support is huge. Thanks very much, Barbara.
Thank you, Barbara. Yeah, we have a couple of other hands up, so I'm going to pass on to Samantha. And I know we're past the hour, but everybody's so interested, Margaret. If everyone's happy to stay on a few more minutes, let's get through a couple more questions. So Samantha, over to you.
Thank you. And thank you so much, Margaret, for an excellent presentation. And thank you for your book, which as a parent, I can tell you just is wonderful and just makes us feel seen and heard in a way that nothing that has come before that has. So thank you. My main question for you is actually, and I don't know if you see the same things, you know, in Australia and Ireland, but in the US, one of the things that we've struggled with is how to adapt you know, pregnancy after loss care specifically for parents who are coming from marginalized backgrounds, whether that is race, you know, LGBTQ status, immigrants, or people who are not native English speakers. I was wondering if in your research you had come across anything like that or had any advice on how to particularly care for parents and make sure that they are feeling as welcome and secure as everybody else. Thank you.
Yeah, so as I said, my study was very small. I didn't have any restrictions on the on the the population in terms of inclusion criteria, I found it very difficult to recruit a sample, and I think it was really because I was trying to get both men and women, and I was trying to get them together. And often, and it was because I think women were gatekeeping. My colleagues who were trying to recruit the sample for me were saying that women were saying, no, he wouldn't be interested in that. So, because I couldn't approach women directly myself. My colleagues, Keelan and Noreen, were telling women about the study and giving them my information. So a lot of the time, I think women were probably, thinking that their partners weren't interested. When I did try and approach, using midwives, asking about, whether there were any other women, they're just, and couples, there just weren't any same-sex couples or any couples from any marginalized backgrounds. There is a huge need for us to do that across all of the maternity services here. Keelan is starting to do work in that area, so I'm hoping that that we will be able to do some work in that area. But again, it needs to be very sensitively done, and there's lots of issues around access, and there's lots of issues around language barriers as well. Thanks, Sam.
Thank you. And yeah, we've experienced a lot of the same challenges with just recruiting, diverse people who want to share. So we get it. Thank you.
Thank you too.
Thanks, Sam, and good luck with your ongoing work. And Adolf, would you like to ask your question?
Yeah, thank you very much, Margaret, for a nice presentation.
Thank you, Adolf.
Very, very interesting, and sharing experience of parents. And I just have like also a similar comment for some small study we did here in Rwanda, where we assess also perinatal loss with the patients, and also we also assess about the providers' experience who have stillbirth in Rwanda, Kigali. So some similar issue you discussed about was how parents want to have to conceive again, so that they can feel more like compensated, if I can say in that way. So they, when we assess, it was small sample, but 69% of the women wanted to conceive again as soon as possible. But majority of them also were scared about the pregnancy, the outcome, how the outcome will be, maybe based on the experience they have, but also they were maybe think that that can happen again. So they are in high risk, of course, but they were scared, but they feel they want to conceive again. Only like 15% are the one who opted for family planning. You understand there were few of them to opt for family planning, but there were many also gap based on our settings, and also health providers. We do have little of few staff to take care of those parents. Currently, we are with some of my colleagues, MFM. Normally, there are few in Rwanda who can still help to take care of those women who have previous history of stillbirth or have high risk of having stillbirth. Now we are trying how we can also work on that to take care of them, to have holistic approach with psychological support, and have skilled to attend skilled personnel like MFM. But what I want just to say was this psychological effect with parents who have stillbirth. But some also assessment we did, which is not paper, was in Rwanda or our lower middle income countries. Even by definition, the stillbirth is defined from 28 weeks. This based on viability. But we do have many women who have stillbirth less than 28 weeks who are possibly considered as miscarriage, but they are still affected as the same level as those who are considered stillbirth to 28 weeks or above. That is another probable challenge, which is also, it can be like public health issue, but neglected as well based on settings and viability. But those parents are also affected. I was also thinking about how we can do another study to assess their psychological effects compared to those one less than 28 weeks, from 22 weeks above. Maybe if that can also be discussed later to be like another study in our settings. Yeah, that was like comment.
That's fantastic. First of all, I'm delighted to hear that fantastic work going on in Rwanda. Well done, Adolphe. And
Yeah, thank you.
I think there's a huge challenge for women whose babies don't meet the criteria, because oftentimes they feel the loss, um they feel the loss hugely, because to them they have lost a baby,
Yeah, sure.
and my colleague Dr. O'Leary talks about that. She talks about how women view their losses, so to healthcare providers, definitions are very cut and dry. We say, oh, 28 weeks, or in my country, 23 weeks, that's a miscarriage, this is a stillbirth. But to women, they're babies. So, it's how women, view what has happened to them. And it's about the provision of, respectful bereavement care. And Sue Steen actually has been doing some good work in Uganda around that as well, about talking to couples and providing very respectful care around the time of their baby's death, um, and can how that then can lay the groundwork, I think, for the subsequent pregnancy. If you're treated well at the time of your baby's death, that can minimize the trauma that the women experience. Obviously we want to reduce the rates of stillbirth. That's taken as a given. But also we want to provide respectful bereavement care, um, at the time of the stillbirth, but also because it will minimize the trauma for the subsequent pregnancy as well. Thank you.
Thanks, Adolphe and Margaret. Great. Any other questions for Margaret while we have her online? See any other hands up?
Hi, this is
Yeah,
Rosa.
oh, so Rosa, yes, sorry, yes, how your hand flashed up and then disappeared again.
No worries, no worries. So my name is Rosa Caparici. I'm a psychotherapist in Montreal, Canada. And delighted to join you all this morning. And thank you, Margaret, for your presentation. And I'm a great admirer of Joanne O'Leary's work, your work, and often direct clients to the Star Legacy Foundation for their online support groups. So I provide bereavement care to perinatal loss parents, and for a time prior to the pandemic, facilitated a support group through the McGill University Health Center. So there are disparate resources available in the community, all doing different types of things. I'm just wondering if in terms of the research, could you direct me to any standards of care that have been developed in bereavement care specifically?
Around clinical bereavement care?
Yes.
Okay, so we've developed bereavement care standards here in Ireland, so I can put those.
In terms of the, sorry, I should be more specific, psychosocial. So, you know, with respect to support groups or in my clinical practice, I mean, I try to keep up with the research, et cetera, but I'm just curious if there has been specific research done in clinical delivery, a research in bereavement care in the clinical environment, and psychosocial needs.
Psychosocial needs. Yeah, I can put in the national, our national bereavement standards are quite comprehensive. I'll put them in there for you to have a look at.
Okay, I appreciate that.
And see what you, so they see what you think, because they go through bereavement care at the time of loss. They also go through ethical support. They go through end of life care, palliative care.
Perhaps if I can ask just one other question, I'm interested in your opinion. When I ran the group, it was a psychoeducational group. It was a closed group with a thematic a framework and grounded in a theoretical framework of meaning making.
Okay.
So Dr. Niemeyer's work.
Yes.
And I did pre and post tests, and it over time evidence showed that it was beneficial. I have heard of other groups which are open, and there is no real structure. It's just the telling of the story over and over again. And I'm just curious. I find that somewhat problematic. I'm not sure how beneficial that is. I was just curious as to your opinion.
Yes, I know what you're saying. It's interesting actually what you're saying there. The fathers in my study, and again, it's, you know, it's a small study. The fathers in my study talked about support groups, and they talked about the challenges of going back to support groups, and like that, not hearing the same stories over and over again, or, you know, new people joining the support groups and being brought back again to the beginning, you know, and hearing the same stories. and that they didn't find it beneficial, that they felt that talking didn't do anything for them, that going in and essentially revisiting the same issue and being brought back to the same point in time really wasn't helpful for them. And so they really only went maybe once, maybe twice, and they stopped going after that. That in terms of you talked about Niemeyer's work in meaning making, that it really wasn't beneficial to them. They felt it far more beneficial if they went off and made their own sense and meaning out of the loss. And usually that involved making something.
Yes.
So making a garden, putting up a tree, you know, manufacturing something, that was a way in which they honored their deceased child, but talking didn't do anything for them. So again, it was interesting, you know.
Margaret, I remember a conversation some months ago, and I can't remember if it was on ISA Presents or something else, but it was about it being quite important to have people in support groups who have a common timeline. So not mixing people who are very recently bereaved with people who maybe had a bereavement a couple of years ago, because it's you're at a very different point.
Different stage.
Yeah. I can't remember where the conversation was, Margaret, but it was a really interesting discussion that's, you know, quite important to be aware of and to, you know, think about it when you're introducing people into support groups, that it's the right environment for them at that time.
Yes, and I think moderation is very important of support groups.
Yes.
So whoever the moderator is,
absolutely.
You know, you can't let kind of support groups run amok.
Exactly. It can do more harm than good, right?
Yes, and run off unsupervised. The other thing as well is it isn't for, I don't think they're for everybody.
Yes.
You know, like in that way, you know, so it sounds like your support groups in terms of meaning making were you know, had a very specific purpose, and so therefore and grounded in a very specific theoretical framework, which was very useful and had a good evidence base. Paula's point is very well made as well, in terms of, you know, having a beginning, a middle, and an end. Otherwise, you can end up, as the fathers in my group talked about, you know, being in that circular washing machine, you know, circuit of being reintroduced to, you know, this back to the same point, and that can be harmful, I think.
Yeah, so I'm particularly interested in the quality of the bereavement care, and perhaps this is an area for further research.
I think there's always a need for further research, you know, in this area. And again, Dr. O'Leary does great work in terms of pregnancy after loss groups, support groups, because again, you know, women who are pregnant again require very, very specific type of support, you know, compared to people who are bereaved. So, you know, as I know, you know, it's a very individual type of support group that's needed.
Yeah, very true.
Rosa, can I just ask if you're connected with the PALE network, Pregnancy and Infant Loss Network in Canada?
Yes, and in fact, I presented at their inaugural conference last year. I initiated a community-based project on the
Good.
perinatal loss experiences of parents.
Excellent.
So yeah, they're excellent.
Great. They're a great network. Yeah.
Good. Thank you.
Okay, fantastic. Adolf, I think that's your old hand up there. I'm not sure if you've still got a question or you're okay. Thanks, Rosa. Yeah, thank you so much. Anybody else? We are way over time, but that just shows how fascinating a topic this is and how dedicated you all are to discussing and listening to it. Would anybody else like to make any comments or have a question before we close? In that case, Margaret, my heartfelt thank you to you for not only this presentation, but for all your years of contributing to ISA. She's been amazing and is nowhere close to stopping any connections with ISA. We hang on to people for life.
Not at all.
Thank you so much. It's fascinating research, and I think everyone found it super interesting, and lots of comments in the chat.
And please, everybody, keep researching this area, because
absolutely
it's kind of been the Cinderella of the pregnancy loss arena for a long time. So, you know, and there's so much work needs to continue in this area. You know.
So this is the last ISA Presents of 2024. Ending on a very good note with Margaret. We will be starting up, you know, another series again hopefully in January. So if any of you, Judith will be reaching out by email, I'm quite sure. But just to let you know that, you know, if anybody is interested to present your work or come together as a group or come up with or a topic that you'd be interested in hearing about, you know, even if it's not your own work, please let us know and we will try to facilitate that. We love having you and having a platform for you to share your stories, your experience, your research, whether you're a parent or a researcher or a clinician, whatever. This is our platform for bringing you all together. So thank you for that. And you will all be getting an email soon also about our General Assembly meeting, which is going to come up in December, but that will come to you by email. So thanks everybody for joining. Thanks for staying on so long. Margaret, tribute to you that everyone's here after an hour and a half.
So, thanks everybody.
Yes, thank you so
much.
Thanks
Paula for inviting me.
Yes, you're welcome, and have a great rest of day, evening, wherever you are. And thank you so much for supporting us. Thank you.
Bye-bye.